Good morning. Good morning. It is my distinct pleasure today to introduce our guest speaker, Dr. Rebecca Hung. Dr. Hung is a professor of medicine at Columbia University College of Medicine and the director of interventional echocardiography at New York Presbyterian Columbia Medical Center. Dr. Hung attended medical school at Washington University in St. Louis and completed her residency in internal medicine and fellowship in cardiology at New York Presbyterian Cornell. Dr. Hung has been involved in valvular heart disease, adult congenital heart disease, and echo core lab research for the last 20 years. She directs the echo core lab at the Cardiovascular Research Foundation, which has been instrumental in many clinical trials, including the partner trials. She is herself the national PI of the SCOT trial and has more than 150 original publications. Dr. Hung is visiting us today as this year's Dr. James Caldwell Visiting Professor. Dr. Caldwell, a distinguished educator himself, established this visiting professorship to recognize excellence in medical education. And we fellows this year invited Dr. Hung for precisely this reason. Dr. Hung has been at the forefront of using innovative technology to teach echo and has been directing various national and regional echo calls for the last 20 years. She has also mentored various fellows, residents, and medical students. I can say that having heard her talks on aortic stenosis and mitral regurgitation yesterday, I already know who I will be grateful to during my upcoming echo boards. So now, without further ado, please join me in welcoming Dr. Rebecca Hung.
Thank you so much. I've actually been having so much fun. It'll be hard for me to leave. But anyway, I just wanted to thank Dr. Caldwell for this wonderful opportunity for me. And I just also want to say go Mizzou. Having been born and raised in St. Louis and having relatives gone to Mizzou, I think we have a tie here that I never realized. So go Mizzou. These are my disclosures. So we're going to talk today about the tricuspid valve, and in the past it's been thought of as the forgotten valve. And what we know about the tricuspid valve is that epidemiologically we will see an increase in the prevalence of the disease with age, as we see with much of valvular heart disease in general. But we also see this divergence in the prevalence between females and males. And so by your 70s, there's a 3 or 4 to 1 ratio of females to males in this disease process. And I think I sometimes refer to this disease as a woman's disease. And you'll see that some of the trials have reflected that difference in the prevalence. Now, why has it been referred to as the forgotten valve? Well, it turns out that a surgeon in 1969, Nina Brunwald, advised a conservative approach to tricuspid regurg, since it was thought that appropriate correction of left-sided valve disease would result in a decrease or even abolition of tricuspid regurg. And this one study back in 1967 has done a tremendous amount of damage to this disease process and our understanding of it. But recently, population-based studies and natural history studies have shown that severe TR actually is associated with poor prognosis. So this is a relatively famous paper by Nath, who it's going to be in every tricuspid regurg talk you ever hear. But it's one of the first studies that has really shown this relationship between severity and mortality. But other studies have gone on to show the same thing. And so this is a study by Lee, also showing that the severity of regurgitation influences survival. But in addition, pulmonary artery pressures and right ventricular dysfunction also influence survival. And this is a paper that really brought home to me the 3 components of this disease that we really must think of together. When you look at all the other outcome studies and the impact of tricuspid regurgitation, it's a voluminous body of literature. So in, obviously, the general population by Nath and a TR population with in a heart failure population, in a mitral regurg population, those patients with severe aortic stenosis or aortic regurgitation, all those populations have are negatively impacted by the existence of severe tricuspid regurgitation. In addition, we know from numerous other studies that in the era of transcatheter device therapy, we also see that tricuspid regurgitation will impact survival. So again, this is in the mitral clip population, 3 different studies showing the impact of tricuspid regurgitation. And then on the transcatheter aortic valve therapy, the partner trial, as well as the STS registry, have again shown that mortality is significantly affected by tricuspid regurgitation. We know also that the prevalence of tricuspid regurg in the setting of other diseases of the left heart is significant. So the smallest population reported is only 6%, but going up to 21% of those patients with other disease processes will have severe tricuspid regurgitation. So the conundrum, there are many, begin with, do we really understand who this target population is? Do we understand the pathophysiology of secondary tricuspid regurg, which forms the largest population of TR? Do we know how to measure TR? And do we know how to treat TR? And all of these questions will not be answered today. But I will hopefully give you at least the background and what we know today about tricuspid regurgitation, and everything starts with anatomy. So I just want to do a brief overview of anatomy. This is a paper, a manuscript that Dimitri and Mark have helped me with illustrations, and will be published hopefully in JACC Imaging this year. But the anatomy of the tricuspid valve, as you can see in these images, obviously it's on the right side of the heart, and it is in discontinuity with its outflow, so that the tricuspid valve and the pulmonic valve are not in fibrous continuity. But in addition, although many times we will image the heart in this upright manner, in truth, obviously, it sits on the diaphragm, and the tricuspid valve is the most anterior and apical of the 4 cardiac valves. And its position is important to understand when we're talking about interventions. In addition, tricuspid valve anatomy itself is extraordinarily variable. Although we believe and we talk about it as a tri-leaflet valve, it is tri-leaflet in only about 65% of the time. In the other 40% of the time, you will see 2 leaflets only. So these are examples of just a bi-leaflet tricuspid valve. And then you can see 4 and up to 6 leaflets in some patients, mainly because of deep folds, but probably clefts, actual clefts in the leaflet. And so again, an issue perhaps for some of our transcatheter devices. The papillae muscle conformation on the right side is very different. There's one really well-defined anterior papillae muscle, that's the white asterisk. There's sometimes a trifid posterior leaflet, posterior papillae muscle, so in the green stars. And then there's a really variable septal leaflet, and a septal papillae muscle, and that's in the blue arrows. And so that variability of the leaflet also extends to the papillae muscles. And then finally, the septal leaflet, and this is the one that gets the tethered, and when we're seeing functional regurgitation, has direct chordal attachments to the septum, no papillae muscle. And so it's these direct chordal attachments to the septum that become some of the problem for us in functional tricuspid regurgitation. You know, again, that when we look at it from a surgical view, that there are many inflow regions. So this coronary sinus comes in, and one of the more consistent parts of the anatomy is that the coronary sinus enters approximately at the commissure between the posterior and septal leaflet, and that the bulge of the aorta sits at the commissure between the anterior septal leaflet. And that also helps us during our interventions, which I'll show you in a minute. Finally, we also have direct myocardial bridges to the base of the leaflet. These direct myocardial bridges are also a significant issue for our transcatheter devices. And then finally, something I learned by going to the pathology suite, in panel C, you see the arrows demarcating the line of the annulus, but you can't actually see an annulus. There is no annulus of the tricuspid valve. There's no fibrous tissue. Histologically, you go directly from atrial myocardium to ventricular myocardium with no annular shelf. And that, again, is a problem for us in the interventional world. The angle of Koch is also important because of the conduction system. I won't go over that, but it's something that surgeons all know about, the location of exactly where or approximately where the AV node and the membranous septum lie. And then we have lots of structures around it, such as the right coronary artery. So the right coronary very consistently comes into the AV groove and comes around the back of the tricuspid valve. So now you know all the anatomy, and you'll hopefully understand some of the transcatheter devices that we have. Now, what is the target population then? Well, if you look at the guidelines, and these are both the European and the American guidelines, all of which for the tricuspid valve are based on really small studies and expert consensus. The U.S. guidelines have at least divided the disease, tricuspid regurgitation disease, into the at-risk, the mild disease, the asymptomatic disease, and the symptomatic disease, similar to all of the valve abnormalities in the guidelines. And then amongst those, the different stages, it divides the characterization into valve anatomy, the severity of the disease, again, based almost entirely upon echocardiographic criteria, and then the hemodynamic consequences, finally ending with symptoms. And so when we look at morphology, and it's important because we will divide the therapy by the morphology of the disease. So primary disease, obviously, we will intervene on in the setting even of possibly asymptomatic disease if there's right ventricular dilatation. But typically for both diseases, the only class 1 indication for intervention is at the time of left heart surgery. Again, a significant problem for us. So if we try to understand the different etiologies of tricuspid regurg, we have a small category of primary disease. This is only about 25% of those patients presenting with TR, including the congenitals, Epstein's anomaly, endocarditis, flail leaflets. This happened to be a patient status post of biopsy, and carcinoid disease, so primary tricuspid and typically pulmonic disease, and then rheumatic disease. These are all examples of primary disease. But one of the most important aspects of primary tricuspid regurgitation is the pacer-induced disease. And so we now know from multiple studies that pacer-induced tricuspid regurg probably occurs in somewhere around 25% of those patients receiving a pacer. And as you can see from multiple different imaging angles, this is all transthoracic on the top and transesophageal on the bottom, that you can actually see the pacing wire impinging on the leaflet and preventing leaflet closure. And this will end up being a large patient population that will require therapy in the future. So the one primary disease process that we will need to address with typically transcatheter devices. So I'm not going to go over a lot of the literature except to say that this is a beautiful review out of Roberto Lang's lab on the identification of and positioning of the leads when they impinge on the tricuspid leaflets. And I think we could feasibly do a better job during implantation to avoid this complication, which we tend to see approximately 7 years after the implantation of a device. But the largest population is secondary or functional tricuspid regurg, and there's really 4 different etiologies here. One is left heart disease, and that includes left ventricular dysfunction as well as valve disease. This is the largest population. And then right ventricular disease itself, pulmonary hypertension, as I already alluded to in that Lee study in the first slide, and then what's called right atrial abnormalities, but really isolated tricuspid annular dilatation, typically in the setting of atrial fibrillation. And so if you look at primary versus secondary is indeed the largest group. If you look at secondary, LV dysfunction and valvular dysfunction is the largest group, followed by pulmonary hypertension, a very small group with primary atrial fibrillation, and then the group with primary right ventricular dysfunction. Pacemakers I stick next to secondary because this is indeed the population that we will be talking about with transcatheter devices. Now, the pathophysiology of tricuspid regurg has, people think they know what happens, and I venture to say that we're still learning about it. But the traditional thinking about functional tricuspid regurgitation is that you will have dilatation out the lateral side of the annulus, because again, that is the unsupported side, and so that's the free wall side, the lateral wall. But in truth, what we don't understand is the role that the right ventricle plays, not only on the tricuspid valve, but on the leaflets and the annulus itself. Now, in order to understand the annulus, we have numerous different imaging modalities. Obviously, we now use CT extensively to do all of our planning. We also have, and this is a new program out using three-dimensional echo and an automated assessment of the annulus. But you have echo and as well as CMR that allows us to really understand the non-planarity of the valve and also its dilatation. But echocardiography has been really one of the main methods that's been used to study the tricuspid valve, and numerous studies have looked at recurrence, actually severity of the disease, but also recurrence of the disease in the setting of surgical repair. And it turns out that the more tethering you see of the leaflet, the greater the severity of the disease, but also the higher the likelihood of recurrence after an annular repair. So now that makes you think, why is that, and why does it predict failure? And it has to do with the right ventricle. So macroscopically and ultrastructurally, et cetera, the RV is very, very different from the LV. It's very thin-walled. It's only 2 to 3 millimeters thick compared to the left ventricle. It has a distinct pattern of conduction with almost a peristaltic contraction out the RV outflow tract. And the right ventricle has a higher proportion of alpha-myosin heavy chains, which result in more rapid but a less energy-efficient contraction. And then finally, it generates less than 1/6 of the work of the LV while moving the same volume of blood. So it's a very, very different structure. And by virtue of the fact that the chamber thickness is less and the ventricular elastance is low, the RV is very afterload dependent. It can tolerate volume for a very long time, but it does not like pressure. And so when you look at, and these are numerous studies, but Erin Spinner, when she was doing her PhD work at Georgia Tech, also looked at the morphology of the ventricle and what determined tenting of the leaflets, which seemed to be so important to defining severity of the disease. And it turns out that patients with a dilated right ventricle had significant displacement of all the papillary muscles away from the center of the ventricle. And then obviously other diseases were also associated, including dilatation of the left ventricle with displacement of the papillary muscles, or if you have dilatation of both ventricles. And so multiple other investigators have shown the same thing, that as the ventricle dilates and the papillary muscles, all the variable papillary muscles, are pulled away from the center, you then get tethering. And so it's about the right ventricle and not necessarily about the valve itself. When you look at the sphericity of the RV in relation to tricuspid regurg, it's very clear that as the ventricle becomes more spherical and less triangular looking, at least on a 4-chamber view, then those patients are the ones that end up developing more tricuspid regurgitation. And so the relevant anatomy is not only the annulus and the tricuspid leaflets itself, but the shape of this right ventricle. And if this is the normal shape, then, oops, sorry, I went backwards. If this is the normal shape, then the patients with pulmonary hypertension and a pressure overloaded ventricle, or in some patients, the just simple motion of the septum toward the left to the left heart will end up causing dilatation in the mid-region of the RV, and this is where the papillary muscles are. And that's what causes tethering of the leaflets, which obviously then have malcoaptation and cause regurgitation. The annulus itself may be less dilated early on, but obviously as you get more tricuspid regurgitation, you'll get more annular dilatation. Now, this has been shown in the pulmonary hypertension literature to be true. And what we know is that it turns out that the septal positioning and the septal motion and the dysynchrony of that septal motion may also play a role in the generation of tricuspid regurg, shown not only in that physiologic study, but in the strain imaging study where they looked at the dilatation of the right ventricle and the location of abnormal motion, abnormal function in the setting of this dilatation. I'm going to skip this slide, but again, looking at RV end systolic volume, and in some cases, end systolic diameter, also again predicting tricuspid regurg. Now, the last category is this idiopathic functional tricuspid regurg, and it just looks like a bigger normal. And so in this patient, you have pure annular dilatation. And with the pure annular dilatation and the basal widening, you then have malcoaptation in the setting of normal leaflet length. Now, there is some remodeling of the leaflets that may also occur, but not enough to obviously close the gap, and therefore tricuspid regurg results. Now, this ends up being the idiopathic associated with age and atrial fibrillation, and indeed only composes about 10%, as I said earlier, of the patients with functional TR. Now, how do we assess the right heart? Well, there are multiple methods again, and I would venture to say that we will be using all of these in the future. CT for planning has been extensively used, but remember we have echocardiography, and we've gone to great lengths to describe how to image the tricuspid valve, and because it sits on the diaphragm, this is actually a valve that has more imaging planes than the mitral valve. And then obviously CMR will be extraordinarily helpful in helping us define right end ventricular size and function. But three-dimensional echo, obviously this is a nearly biblical correlation, but the correlation with CMR and three-dimensional echo RV volumes is very, very good. And so we will in the future also not bother to put the 80-year-old into the magnet and just get a three-dimensional echo. But RV function is also something that we struggle with. And in the ASC guidelines, there are multiple different parameters that have been used to judge function. But I believe, for me, the answer will end up probably being global longitudinal strain. And so multiple studies, again, showing that global longitudinal strain, and this is global, which includes the septum. So I believe that instead of just looking at the RV free wall in the setting of tricuspid regurg, again, the septum plays a large role. And so we've been looking at the global right ventricular function, including the septum. And the global longitudinal function, again, had the highest correlation with the CMR right ventricular ejection fraction. And I believe, again, may be the key for us. This is an illustration that hopefully will be coming out in our publication on the Navigate Transcatheter Tricuspid Valve Replacement Device, showing that the global right ventricular strain may again be able to predict in-hospital outcomes. So quantitation of TR, another problem for us. We have in the past, as I mentioned, looked at just diameter. There are numerous studies showing that just the annular size alone predicts severity of tricuspid regurg. And Dreyfus has been the lead author advocating for, and the scientist advocating for intervention on the valve as soon as it begins to dilate. And so there is a CT surgery network trial that is now looking at repair of the tricuspid valve in the setting of dilatation and only mild or moderate tricuspid regurgitation, and that trial is ongoing, and we may have an answer about whether or not we should just intervene based on diameter alone. But what we obviously do as echocardiographers is evaluate multiple parameters on echo. We look at obviously the anatomy and morphology, but also color flow Doppler, pulse Doppler, and continuous wave Doppler. And all of these methods obviously have been relatively standardized for the mitral valve, but for the tricuspid valve, I think we still have, it's a work in progress. And when you develop tables like this, which are so complicated and have so many variables, then we clearly really don't know what the heck we're doing, and we need to really concentrate on trying to figure out how to quantify this disease. And the guidelines to date have only quantified using a single measure, and that is PISA. Now, it turns out that PISA has a lot of limitations, both on the mitral side, as we discussed yesterday with the fellows, but also on the tricuspid side. It assumes a flat surface. But we're just talking now about tenting of the valve, so it's not a flat surface. In addition, it assumes a circular orifice. But we know already from multiple studies on the tricuspid, but this is a three-dimensional color Doppler view of the tricuspid valve, that it is not a circle. It typically is a crescent. And that is also shown by this biplane image of Pisa, where you see that you have a minor and a major dimension, and therefore that you cannot fulfill the third assumption, which is it assumes a hemispheric proximal flow convergence. And then finally, it assumes that it's a constant over time. And we know that for functional disease, there is a significant time variability of the regurgitant orifice. And so consequently, we've relied more heavily on three-dimensional planimetry of the vena contracta area, which has been shown to be to have some utility and accuracy with defining severity of disease. And so in this review, we have attempted to also quantify, not only using three-dimensional echo, but quantify using the standard methods that one would think of for the mitral valve, which is quantitative Doppler. In order to do the quantitative Doppler, we use a biplane image because it's an elliptical orifice, and then we pulse Doppler at the annular plane to get the stroke volume across the tricuspid valve and diastole, and then we subtract any forward stroke volume that we calculate, whether or not it's from the left or the right heart. But the problem with TR is not that we can't quantify it. I believe that we found the answer, and we've used all of those methods in the trials to date, but that volume overload is well tolerated. And there's no prior interventional therapy available, and the only guideline-directed medical therapy is a diuretic. There's a significantly poor understanding of the grading, since people are relying heavily on color Doppler jet area, percent area of the right atrium, and the right atrium, unfortunately, in the setting of chronic volume overload, is massive. And so this is just an example. We got them even bigger than this. Of the right atrial size in a patient that's come to us for a transcatheter device. That's bigger than my head. So it's just enormous. And so these are the patients that are coming to us. And they don't just have 40 millimeters squared or 0.4 centimeters squared regurgitant orifices. They've got centimeters squared. This one's a 2 centimeter squared. We had a patient come to trial with a 4.5 centimeter squared regurgitant orifice. It's bigger than the mitral valve. And so these are the patients that we cannot describe using the current grading scheme. And toward that end, Pepe Zamorano and I suggested that we extend this grading scheme out to appropriately capture the grades of these regurgitant lesions. And so massive has already been mentioned in the European guidelines. We went on to torrential, and then of course Steve Bowling likes to say, and then there's Becky's oh my God stage. But there is a stage beyond torrential, because again we've had 4 centimeters squared come to us and successfully have a device implanted. So the other way that we believe we may be able to use is quantitation by CMR, and obviously there are multiple ways of doing this. We believe that the standard using phase contrast methodology may work, but it turns out that the pitfalls of some of these methods are quite clear when you look at the data and you speak to people who have been doing CMR, tricuspid regurg quantification for some time, and that's that we underestimate the volume. So if you look at the CMR versus echocardiographic, you know that if you've got some jet, that you can't have zero regurgitation, and so CMR, unfortunately, in this correlation study, actually records negative regurgitant volume on some patients. So it just can't be right. So we are going to have to figure that one out, and I don't actually trust CMR at this time. But the other thing that's come about is the use of CMR to actually planimeter not only an area of the low velocity flows, essentially, but also to planimeter in the short axis view what they believe is with this group, and this is again Roberto Lang's group, believe is the vena contracta area. And so there are lots of different methods now that are being investigated, and I think in the end we will have a better idea of the treatment, of the severity of regurgitation. Now, if we go on to treatment, then it's pretty darn easy, because the only guideline-directed medical therapy is a diuretic. There's nothing else except for treatment of the left-sided disease that will actually treat tricuspid valve. And so the only other intervention will be surgery. And the problem is that of the 2.5 million cases that exist at this time, with 217,000, and these are rough back-of-the-napkin calculations based on what we believe is the prevalence of the disease, annual disease of about 200,000, and annual mitral regurg surgeries, which are probably more than this, with a fraction of those getting annual tricuspid valve regurgitation. It really is the forgotten valve. And there are lots of different surgical techniques, the majority of which currently that are being performed now are repair techniques, but obviously don't forget that you have replacement techniques that are also possible. But why then, since we are pretty clear about treating significant TR at the time of left heart surgery, does it continue to go untreated? And it turns out that there are a lot of misconceptions about TR at the time of surgery, that TR resolves following surgery. This was that Nina Brunwald postulate, but we know that it doesn't. It actually gets worse. That an underestimation of TR severity occurs under anesthesia. Definitely, we know that to be true. And so when you're making your plan for surgery, it should really be done pre-procedurally. The overestimation of surgical risk when concomitant tricuspid valve surgery is performed. Their early studies showed an increased risk, but most of the later studies show that there's absolutely no increased risk to added on when you do a tricuspid repair after the mitral valve surgery, and then the progressive nature of the disease, which I've already shown you multiple slides on. It turns out that the surgical mortality for this disease in green here, and this is, again, looking at the National Inpatient survey, that the in-hospital mortality across the decade of this survey has not changed. And that's a pretty sad statement. So in-hospital mortality of about 9%, this has been confirmed in Europe as well in their databases, and tricuspid replacement obviously is still performed in the majority of cases, but the rate of increase in the repair group is obviously increasing at a much faster rate than the replacement, and so repair will overcome replacement as the surgical intervention. And when you look at isolated repair or replacement and at high in-hospital mortality, there are other problems that also exist. High pacemaker rate, high acute injury requiring dialysis, protracted hospitalizations, and substantial cost independent of the type of surgery. But there are also many studies that suggest that actually tricuspid repair has a lower risk operative mortality than replacement. And the problem with that is the patients that require replacement, again, because their leaflets are so tethered, their annulus is so massively dilated, end up having cirrhosis, a history of a pacemaker, or histories of prior valve surgery, and long-standing disease. And so we are operating clearly too late on most of these patients. In addition, other studies have gone on to show that despite early belief that replacement had a higher mortality, it turns out again that independent of the type of surgery, that really what determines outcomes in the surgical population are all of these other factors, again pointing to the fact in the setting of liver cirrhosis, anemia, low protein, and renal failure, that we are operating too late on this disease process. In addition, we are operating now, we're beginning to see more repairs than replacements, and this is an imperfect solution. We know that practically immediately after you get out of the OR, 34% of patients are going to have moderate or severe tricuspid regurg. That's a pretty bad rate. Now, the surgeons don't tell you that, because all they see is the intraprocedural TEE, and they say, I took away all of the tricuspid regurg. 30% at 3 months are going to have significant tricuspid regurg. And then at 5 years, you have even worse. Almost 50% of patients will end up with moderate or severe tricuspid regurg. And so eliminating TR with an annuloplasty device is not the solution. Are we actually doing the wrong operation? And so Dreyfus published this beautiful review of his take on how we should treat tricuspid regurgitation. It forms some of the basis of the CTSN network trial. And he looks at the severity of disease, the tricuspid annular leaflet coaptation, and then decides on the surgery based on that. But the problem is that he is postulating that the only surgical intervention typically is a repair, and he does not take into account the missing variables, which are pulmonary hypertension and the measure of function. So if we look at the different stages, and this is just my take on the different stages, this is a manuscript that has been already submitted to Euro-Interventions in time for the London Valve meeting. But if you look at the different stages, and again, we like to add more stages for tricuspid regurg. Then as you start to progress from no tricuspid regurg to mild to moderate but RV dilatation beginning to now more significant RV dilatation and then massive dilatation, you see that it goes along with probably the grade of tricuspid regurgitation, but also on the severity of right ventricular dysfunction and remodeling. And indeed, if you look at the medical therapy, the only thing you've got is the diuretic, and then many patients come in and they have repeated paracenteses for significant ascites that just recurs, and so they have it every month. They can come in for a paracentesis, and so the surgical therapy has, to date, relied on repair, but in fact, replacement as you begin to get into the higher risk stages is what has also been performed, and now what we will have is percutaneous devices, which may allow us to potentially target earlier stages in the disease, but also treat the patients who have prohibitive risk and are not considered surgical candidates. So moving on then to transcatheter devices for the tricuspid valve. This is a beautiful valve because I love it, but also because it's got a lot of ways to get to it. So now you can approach the tricuspid valve from the SVC, IVC. You can do it transapically, you can do it transatrially. There haven't been a lot of transapical, but transatrial there have been approaches to the tricuspid valve. And then you've got a lot of targets. You've got the leaflet, the annulus, and then your vena cava. I wrote IVC, but really both vena cava, and then the valve itself. And so when you look at the new technologies, and this is old already. There's more technology out there than this. The new transcatheter tricuspid technologies that are out there, you can divide it in my mind into the annuloplasty devices, leaflet type devices, of which I'll show two of these, and then the stented valves in the IVC, SVC, and then finally we now have valve replacement devices. The annuloplasty devices I'll show you are the Triline device and the Cardioband. Triline was the first to report out the early feasibility, their early feasibility results, and again, I was the national PI for that. The Cardioband has just gotten CE mark for their tricuspid valve and will be beginning their U.S. trials now, actually. Fortec is a device that is, anchors at the lateral annulus and then is basically pulled to reduce the space between the lateral annulus and the septum or the posterior leaflet. The Millipede is another annular device, and these are anchors that basically screw into the annulus. A couple of patients have been done using a transeptal device. And then the PASTA device is the brainchild of the NIH with Dr. Letterman, where he's using off-the-shelf equipment to bicuspidize this valve. And there have been 3 performed in humans. All of them have pulled out. So I don't think we're going to be seeing that very long. And then the cardiac implants is a brand new device, only in animal studies right now. This is a device that they lay across the annulus and they anchor it there, but they don't do anything for about 6 months. They allow it to fibrose onto the annulus, and it has obviously an anchor, a string or a wire running throughout this device, and then at a later time, once the fibrosis has been confirmed, they will then shorten they'll pull on the wire, and they'll be able to reduce the annular size. The leaflet devices I'll describe in a minute, and then the stented valves that I won't show you, but the idea behind this is it's palliative. So the patients come in, they have ascites, they have shortness of breath, they have a massive edema, and so these devices are valved stents in the SVC and IVC, which then prevent backflow into the hepatic and IVC. And then finally, we'll talk about one of the replacement devices. And the devices we have at Columbia, there are 5 different devices that we've used, but I'll only describe, as I said, a couple of these. So annular devices, to talk about the tri-line device. So this is a bicuspidization with a surgical predicate being the K procedure. And in this procedure, you entirely guided, initially gross movement by fluoro, fine motion by echo. And so this is a device where, oops, sorry, pushed the wrong thing, where you, you guide the wire delivery catheter underneath the annulus. You deploy in the annulus. Now remember what I said about the annulus. There really is no annulus. And so the idea behind this is obviously to get it as far away from the hinge point as possible, to get as much tissue as possible without nailing the right coronary artery. And so once this device comes down, a pledgeted suture is then deployed first on the ventricular side and then on the atrial side in order to support the suture. And then once the full pledget is deployed, you do the whole thing over again at a set distance away. Now, once you've now done the second device, then you can pull the two wires together, anchor them to one of the devices, and we always anchor to the first device. And then from there, you can bicuspidize the valve. This does require, it's a transjugular approach. Two 14 French sheaths are inserted in order to do this double technique, and then as you can see, we pull them together and cinch them, and have an anchor device and a cutting device after that, and then you've effectively bicuspidized the valve without actually removing any leaflets. So all three leaflets are obviously still intact. And so guiding this, and I'm not going to show you the whole procedure, but this is just after we put in the two devices. And so we're now doing that pulling and cinching technique where we watch continuously on echo, and we're able to see when the two pledgeted sutures are right next to each other. You see this also on fluoro. And then you're able to bicuspidize the valve. So similar to what we do for the mitral clip, we can gain in to see the leaflets, and the pledgeted sutures we gain out if we want to see what's below there, and so or to see the shape of this annulus. And you can see then on this procedure that we've effectively reduced the annular size. No idea why this is not advancing. But what I wanted to show you also is what's coming in the future, and I've been told by Phillips that I can show this. But this is new imaging technology, software technology that will be available soon, and this is a moving light source. And so the moving light source will allow us to, again, show the interventionalists different things. We can move the light source along the surface, and these are the two pledgeted sutures with a little knot on each suture. And so there's a knot in the pledget, or we can move the light source below, and so that you can look from up above. So here's the light source below the annulus and looking up at your catheter and location of the catheter in relation to the leaflets. And all of this technology has been designed specifically for our transcatheter devices, and it will make it much easier for us to see and to communicate with our interventionalists. Again, this is that case that I just went through. You can see the significant reduction in the oh my God to the okay, but it's still pretty severe, and so again, may not be a solution. But this is the first trial to have been published, and shows pretty much what all the trials have shown. That these are elderly patients, yes, that there's primarily females coming to trial. The majority, obviously all of them have symptoms or we wouldn't be doing this. They all have concomitant disease, much of it left-sided. Majority of the patients have had already their left heart operated on. They are in atrial fibrillation majority of the time. This should be on the diuretics. Sorry, they're 100% on the diuretics. And this procedure had 100% acute procedural success, but then pullouts have been an issue with about 20% pullout rate, and they are now redesigning the pledget itself. But what we were able to show, and I'm sorry this doesn't show up very well, is a significant reduction in annular area, and then associated with that, a reduction in PISA regurgitant orifice area, as well as quantitative regurgitant orifice. And then, again, I'm sorry it doesn't show up well, but we found this relationship to be true relatively routinely throughout the trials that we've been core lab for. that the PISA EROA and the quantitative EROA the PISA underestimates by about 1.6 to 1.8 fold. In addition, then, we showed the regurgitative volume is decreased and a significant increase in forward stroke volume, which is obviously what one hopes to show. Related to that is the functional improvement, both of a 6-minute walk and Minnesota Living with Heart Failure. Those patients, a majority of them became class 1 and 2 after the device. But the problem with all of these annular devices, similar to the surgical side, is that they will recur. So at 12 months, this is the follow-up of the first 15 patients. You can see that there's been some loss of the PISA EROA reduction. There's been some loss in the left ventricular stroke volume gains. And so we are indeed looking at a device similar to surgical that may not have the durability that we need in some of these patients. This device is easy to do, and in the patient that we had that recurred, we went ahead and brought her back and put another set of pledgets in, and she's again down to mild and feeling better. The 2 trials, the SCOUT-1 has been extended, SCOUT-2 is ongoing and enrolling in Europe. The Cardioband device, and this is a movie from, I should get a movie for the tricuspid, this is a movie for the mitral, but the Cardioband device acts like an incomplete surgical ring. And in the fabric, you place anchors and then anchor by screwing down the anchors through the fabric and into the myocardium. And so their attachment site is not just to the thin portion of the shelf of the pseudo annulus, but actually into the myocardium itself. And so this device has just received CE mark 2 weeks ago for the tricuspid side, and the trial is enrolling currently. So this will be one of the first devices probably to have availability in the United States. And this is a device, again, guided by echo. You do not proceed until the echocardiographer says you can proceed. So it's one of the best parts of my day. I just like, how many times does the echo person get to say, no, you can't do that yet? So this is guided by echo. We extensively use FlexiSlice. This is a GE software capability where you can guide the 2-dimensional imaging by the 3-dimensional image. And so that way we can align our 2-dimensional images to be coaxial with the catheter and actually image the anchor going into the myocardium. This is one example of the tricuspid cardioband from Azim Latib, showing again that we can really significantly reduce the annular distance and take away a huge portion of tricuspid regurgitation. But it is an annular repair device. And so the outcomes of that annular repair device are going to be similar to the surgical ones, which is that we can't take it all away. We do show significant reduction in the septolateral dimension, which you saw, and we show significant reduction in regurgitant PISA as well as the vena contractus, the maximum vena contractus of the jet. We also show nearly significant increase in left ventricular stroke volume, with concomitant functional improvement, but we do not take away all of the regurgitation, and there are some patients that actually do not get better. The leaflet devices are something very different. So mitral clip, have you done any mitral clips on the tricuspid here? It's it's challenging, but we currently with our current mitral clip devices, I know that you have, so maybe Mark's not here, but anyway, you have to really miskey the device, and you have to do all sorts of crazy things in order to get it down to the tricuspid valve. But the European, this publication by Georg Nikonik was just the early European experience with the mitral clip. There's been hundreds of these put in on an off-label use, and he showed again that there was significant improvement in New York Heart Association classification and reduction in the amount of regurgitation. And this is one of our cases, and you have to be a little bit careful because this was radiation-induced valvulopathy, so the leaflets are a little bit thickened. But you can see that we can guide, similar to the mitral clip, we can guide this using echocardiography and get ourselves to to see the leaflets in the clip arms and get a good result. This was a 2-clip repaired result. It's also been done in patients with pacemakers. And so both the SCOUT trial, which allowed pacemakers, the Cardioband trial, which also allowed pacemakers, are all going to be devices because they're in the annulus and not in the orifice that will allow pacemakers. But the tricuspid clip, it turns out, can also be performed in those patients with pacemaking leads. And so over 500 cases have been performed worldwide. The transfemoral approach is the default approach. 1 to 2 clips is typical. Anteroseptal is typically the target, since that's in the majority of cases where the leak is. And then we prefer TEE, which is superior to, we believe, ICE imaging, given the fact that you have to so precisely position this device. And obviously there are a lot of challenges since the leaflets are thin. The coaptation gaps are humongous. And there's a whole lot of chordae in there, particularly with the septum. But the Triluminate study, which is a multinational trial of the tricuspid NT device on the 5 sites in the US and then multiple other sites in Europe, is now enrolling very, very quickly. The Pascal device will be another solution to the clipping device, and this is also coming, but has not been used yet in any consistent way on the tricuspid side. Now, the other leaflet device, I call it a leaflet device, is the spacer device. This is the Forma system, and this is basically allowing the leaflets to close against something instead of nothing. And so this spacer device, the Forma trial, this is where, and again, we had some EROs that were just astounding. We couldn't believe they were alive. But this is a trial that ended up enrolling the compassionate, the cohort C patient, the patients who really had nothing left. And so one has to really, in that setting, look at the results of this trial. And you can see, and I'm not going to go through all the data because we're running behind here, that the EROA as a group definitely decreased. There are some patients who we just couldn't help. That the New York Heart Association class definitely got better, but there were some patients who, again, in cohort C are just never going to survive. And then we had, as a group, again, improvements in 6-minute walk and KCCQ, but this patient population is one that we believe may not be treatable. And so to give this device a fair shot, the device will, they're on hold right now to improve the anchor as well as look at their data, but it will probably come back in the next few months and allow us to again implant the device. Our first device went into this patient, so this was our very first device. This was a very small, tiny woman, a BSA of about 1.4, and this device went in beautifully, obviously right down the center, cutting the regurgitation literally in more than half. The total residual EROA was still in the massive range, but certainly we had taken it down significantly. And this is a patient who was incapacitated, massive ascites. She's a tiny little lady. It was just, the ascites was, way, she could barely sit. And she went from that to driving. She's a nun, and she drives around all of her colleagues to the store now, and she's like able to do everything. She's absolutely loved this device, and so this really gave us the hope and belief that in some patients this device may be the answer. Cable implants, again, I think I'll just briefly show them to you, but I'm not going to show you any actual patients. But again, the idea is to prevent the backflow and the symptomatology associated with that. There is a single-site trial, the HOVER trial by Brian O'Neill, that it's enrolling now at Temple. And I'm not going to, we'll just keep moving. The Tri-Valve registry was an multinational registry where we also contributed a number of patients to look and see about the use of some of these devices around the world, and you can see that a number of different devices were included, and the TR baseline, again, we have a lot of room to go. We were not able to reduce the regurgitation by more than about 50% in most cases. And so there has to be some other solution, and we believe that the future may be transcatheter tricuspid valve replacement. This is the Trisol device. It's a single leaflet device, really bizarre looking, right? So if you kind of think St. Jude's mechanical device and then make it a leaflet. That's what this looks like. This is all preclinical work. This is not done, has not been implanted in patients. The reason behind it, and you can see these big sail-like leaflets, and the reason behind it is to allow, because it's so big, to actually give the right ventricle some closing volume. So let's just think about that for a second. Many of our patients have some RV dysfunction, and once you take away all the regurgitation, which typically the replacement devices do, you take it all away, then the afterload on the right ventricle significantly goes up and we have acute RV failure. We've seen it already in some of our transcatheter devices. The surgeons see it all the time in the operating room. And so the theory behind the Trisol is that with these big sail-like leaflets, there is a greater closing volume which will act as an afterload reduction device. So we'll see. Obviously hasn't been put into any patients yet. The closing volume, again, felt to be probably a good 20 cc's, 10 to 20 cc's would be what works. And then the only other device to show you, and I'll close now, is the Navigate device. So the Navigate has now been put into 16 patients in the world. Columbia has put in 5. Hopefully you'll get to see that in publication form soon. We again use FlexiSlice to position the device. This is a transatrial approach. You can see the device being deployed, and this device takes away all regurgitation. So there is almost nothing, down to trivial, from massive. And this patient, this specific patient, went home in 5 days and called us from the shopping mall saying that all she really wanted to do was to be able to go out with her daughter and play and shop, and that's what she was doing. So this is a device that I think may in the end offer us a lot of options. I don't think we understand everything. I think that we are working on what it means to be efficacious. What is efficacy? We do believe that we have a better idea of pathophysiology and what might work in various disease processes. I believe that we have an idea of what we need to do to better define regurgitation severity, but there are so many questions left that I think this field is wide open for more clinical researchers, which I hope we'll find in this audience. So thanks for your attention. Sorry, I ran over. It's all perfectly clear, right? It's like we know nothing, so this is a great field.
One thing I think is a wonderful review. Thank you so much. One thing I think happens if the tricuspid regurg is secondary to other causes, if you resolve those other causes, is it clear that the tricuspid comes back to the original state?
The tricuspid regurg does not resolve, and so that's the problem, with Nina Brunwald's original statement in 1967. It doesn't go away, and so people have asked, well, why doesn't it go away? Well, if you put in a mitral valve replacement, the left atrial pressures are still not normal, right? And so you still end up having higher left atrial pressures than without a valve in there. And the same is true if you put an aortic valve in there. In addition, over time, there might have already been changes to the pulmonary circulation secondary to the mitral regurgitation or mitral stenosis or whatever. And those chronic changes in the pulmonary circulation will lead to increased pressure on the right heart. And that RV is just really super sensitive. So we believe that all of those things occur. In addition, that there's abnormalities of the septum even after surgery and the loss of the pericardial constraint. Whether that has a role as well in pulling out the papillary muscle further away from the lateral wall, we don't know. But I think all of those things are possible reasons why, even after repair, you continue to see TR and it continues to get worse.